The patient is going to be immobilized, non-weight bearing. They'll most likely be immobilized in front slab, in maximal plantar flexion for the non-operative pathway. In the surgical pathway, the surgeon will decide what angle that they want the ankle to be immobilized at. And there is surgeon variability within that decision. Some surgeons like it to be immobilized in 30, some in 10, and there's some surgeons that will immobilize it in plantar-grade. All right, so that is surgical preference. However, most commonly, the surgeon will repair the Achilles tendon tension relative to the contralateral non-injured side, and then it will be immobilized in that position. Okay, so they'll build it up and so it will stay in that position, which is the resting angle of the contralateral side. And that makes sense to me. So that's what we expect to see when they come out of their cast or their acute immobilization period in the first 2 weeks. Moving forward into week 3 or 4, it's been shown to be effective and safe to do early range of movement, but at low loads and not past plantar-grade. So I'll demonstrate that with Beth now, popping something under the knee just to take pressure off the calf. So take the calf off slack at the knee. And with a very light TheraBand or bit of tubing, we're going to place that around. Beth is going to take one in each hand. All right. And while we're doing this, it's very important, Beth, that we're going to start in this maximal plantar flex position, okay? And you can come up gently, yeah, but not past 90 degrees at the ankle, which is plantar-grade, okay? And then you can just push gently down there. Now this is essentially no resistance that Beth is pushing against, less than 1 kilo, and pushing down through here, and just very, very gently using her calf to progress into this range of movement, okay? Reinforcing that this is not past plantar-grade. So after we've started our basic active range of movement that is not going to go past plantar-grade and is not going to be more than 1 kilo of resistance that you're pushing against, we can then go into some seated isometric contractions in a shortened protected position of the ankle. Now, this is key that when we're starting to develop our strength in this sort of week 3 to 4 into week 5 to 6 period, that the angle of the ankle is maintained in a shortened and protected position. All right. Now this is appropriate for both the surgical and the non-operative pathways. By having the ankle in this position, we're still approximating the tendon ends and we're not going to be getting any lengthening through the tendon. Okay. So that is one risk of doing an early loading pathway, is that if you do it incorrectly and you start loading in week 3, 4, 5, 6, you do it in a lengthened position and the Achilles tendon lengthens out, and that, once it has occurred, cannot be recouped after that's occurred. All right. So with Beth sitting with the ankle in a protected and shortened position, we can then start to do some light isometric contractions. So Beth, without moving the ankle, just gently pressing up and matching my resistance, yeah, of about 2 kilos to begin with, okay, and resting, and then progressing there into 5 kilos placed on the knee, and something, if Beth holds that, and then, so not lifting the heel off the ground, but matching the weight that's on your knee, doing 5 5-second holds in this position, so gently just contracting the calf into the resistance but not moving it, holding there. Okay, so there's no change in angle or change in length of the ankle. And that is a key consideration when we're doing an early loading or accelerated rehab approach. When we're doing our early loading approach and we're doing our isometric contractions in a shortened and protected position, it's sensible to limit the load that you're putting through the repair to 10 kilos at the end of the 4th week and up to 20 kilos or not beyond 20 kilos at the end of the 6th week. Okay, that is based off the safe loading limits that's demonstrated by the Rendex study in 2022. Now, other considerations, if we're doing our Willits protocol or our classic gap knot protocol, is around the 6th week or the 5th week, we're going to start to reduce the wedges in the boot to slowly lengthen the Achilles tendon down so that the patient can begin walking with a normal gait. Now, a key consideration here is that in the non-operative pathway, because we're waiting for the tendon ends to heal within the paratenon, it makes sense to be a little bit more conservative with our reduction of our heel raise height. So for me, that takes place, we don't remove any wedges until the 8th week and 1 per week thereafter, so that we're more walking in plantigrade between week 10 to week 12, and we're walking in plantigrade within the boot at this stage. In the surgical pathway, majority of surgeons and the pathways that have been published are happy to remove a wedge in the 5th week, the 6th week, so that between the 7th and 8th week, we're walking with the heel in plantigrade in a boot over ground. So reinforcing that, in the surgical pathway, we can be walking with the heel on the ground around the 8th week, slowly removing 1 wedge per week from the 5th, 6th week. Do you get that? In the non-operative pathway, delaying that to allow the tendon healing process to occur a little bit longer, so not removing any wedges until the 8th week, so that we're walking from the 10th week in plantigrade or within the boot. So in stage 2, we can go into our protected loading phase. So this is week 7 to week 12. So we've done our first acute 6-week block. We're now into our second block. So with Beth sitting here, key things that we want to think about and acknowledging what's happening in the tendon and what we know about tendon lengthening in the research. We know that the tendon lengthens maximally between week 6 and week 12, okay? So in this protected loading block from week 6 to 12, that's when the maximum amount of tendon lengthening occurs. So it's so important that we do all our loading in protected ranges of movement, okay? We don't passively stretch the ankle into dorsiflexion. We don't try to actively restore ankle range of movement in this stage. We let the tendon strengthen, remodel, knowing that the range of movement will come down the track, okay? Another consideration or a learning when you manage Achilles tendon ruptures is that they very rarely heal stiff, okay? They most commonly heal long, all right? So we don't want to be chasing range, particularly in the first 12 weeks, all right? So acknowledging that in our protected loading phase, we're still doing our loading in a protected and shortened range of movement. However, what we can do is we can slowly start to progress from light isometrics to isotonics, and we can do that with weights that we're comfortable tolerating, and we've already demonstrated that because we've held sustained isometric contractions over the last couple of weeks at these weights. So if we use 5 kilos as a starting point, we're now going to pop that on the end of Beth's knee, if you can hold that. Beth's ankle is still in a protected range of movement. Okay. One thing that we can do to reduce the tendon lengthening effects, besides not stretching the tendon and not loading the tendon at long muscle lengths, is to really prioritize the strength in this inner range position. Okay. So in the week 7 to 12, I like to go really hard at strengthening inner range calf strength. Now, from this position, Beth, if you can just demonstrate a light isotonic, so just lifting up with slow and controlled tempo and slowly down. Good. And if we can do 5 to 6 reps of this. So really slow, 2 seconds up, 2 seconds down. And just noting here again that there's no tendon lengthening occurring, okay? So we're gaining strength in a shortened position. What we'll notice at this stage, if you have a rest there, Beth, is that some patients will try to really compensate or dominate through their FHL muscle, and they'll grip through their toes. So what I sometimes use, if that patient is doing that strategy, is I'll place a small block under their MTP joints that ends there. I'll just grab that now. So for instance, grabbing a small block, if you can imagine this, okay, with their MTP joints off the block, okay, their big toe now is ineffective as a lever, and you can raise up from that position, okay, and this is true plantar flexion occurring, and it's eliminating the FHL, probably that block being a little bit higher for Beth, so that she's lifting the big toe off the ground as she's doing it.